So we are going to focus on the treatment of ruptured brain aneurysms with flow diverters. How do you move it? With the mouse, yeah? Sorry. So originally, the flow diverters were indicated for the treatment of wide neck aneurysms located at the petrous or the clinoid segment of the carotid artery. But very rapidly, in the last 10 years, the indications for the use of flow diverters expanded to small aneurysms, blister aneurysms, multiple aneurysms in the same artery, ACOM aneurysms, anterior cerebral aneurysms, bifurcation, M1, M3, M4, recurrent, dissecting, basilar, posterior circulation aneurysms. Basically, flow diverters are used in a wide range of indications, but probably the last frontier for flow diverters is ruptured aneurysms. And what's the reason we don't use flow diverters for ruptured aneurysms? Basically, because of two reasons. Because it requires months to achieve full aneurysm exclusion if we place a flow diverter, and we fear rebleeding. And the second is that because of the need for double antiplatelets, we fear hemorrhagic complications. So the fear of rebleeding and the fear of hemorrhagic complications are the reasons why we don't generally place a flow diverter on the acute phase of subarachnoid hemorrhage. If we check a very interesting study, a meta-analysis done 4 years ago, evaluating the use of flow diverters in the treatment of ruptured aneurysms, the meta-analysis showed a low rebleeding rate, a high durable and geographic occlusion of the aneurysm, but high rate of thromboembolic and hemorrhagic complications. So two things that are very important: high degree of technical success and adverse events appear more common. When we check more series done in the recent times, we find four very interesting things. First of all, a very low rate of rebleedings, very low rate of rebleeding, almost zero. Ischemic complications are by far more common than hemorrhagic complications because we fear hemorrhagic, but ischemic are more common. Hemorrhagic complications are related to the EVD placement, to ventriculostomy placement, and this is very important. And there are very high rates of complete aneurysm occlusion on follow-up. So it looks that the rebleeding thing is not so important. For some reason, it goes against the mantra of the only protected aneurysm is the one that is occluded by coils. Here, we implant a flow diverter, the aneurysm is still patent, but for some reason, it doesn't rebleed. So the need for double antiplatelet is basically the most important thing in this subset. We don't like double antiplatelet in the acute phase of hemorrhage because of certain beliefs that we have in double antiplatelet use, with the fear of hemorrhagic complication. But the most important thing is that we really fear, or it complicates the neurosurgical management of the patient. And we deal here with the ventriculostomy shunts, etc. We all know that this is something that is not comfortable. We don't feel comfortable with that. When we check all the same studies that dealt with aneurysm that ruptured, you will find that the antiplatelet plan was very varied in terms of the regimes. Every single author used a completely different regime of antiplatelet therapy. And if you check the antiplatelet testing, you will be surprised by the fact that the vast majority of authors don't test the effects of antiplatelets. So various regimes, including aspirin prasugrel or aspirin clopidogrel or tirofiban and abcisimac or other combinations, but it's not quite clear if there is need to test the antiplatelet effects, while in fact the vast majority of studies don't test it. So we believe that this wide variation in patient management, including the diverse antiplatelet regimes, are important factors influencing the rate of ischemic and hemorrhagic complications. This is what we reported a couple of years ago. We found variations in EVD placement, considerations for EVD placement, variation in intraprocedural anticoagulation. Many studies continue with anticoagulation after the flow diverter implant. Many studies use 2B3A antagonists during the procedure. Many studies don't use antiplatelet checking, and they use different types, doses, and timing of administration of double antiplatelets. So, and the discussion regarding ventriculoperitoneal shunt is like, it's not clear at all. Different protocols in different studies. So, guidelines are needed. Here we focus, and I will present what we do here in our center. What is our protocol in treating aneurysms that rupture, focusing in EVD placement, how do we manage the EVD, the antiplatelet regime, the perioperative management, and complications. So in general, as in every center, are treated preferentially by coiling, no doubt. But sometimes we use flow diverters as flow diverters as monotherapy, especially for aneurysms that are very, very small, wide neck, difficult to coil, blister aneurysms, small dissecting, or fusiform aneurysms. What we gathered here are patients that were treated only in the first 4 days of subarachnoid hemorrhage. Those that were treated after 4 days were excluded. So we wanted to see what happens in the most critical phase of hemorrhage, the 96 hours after the subarachnoid hemorrhage. If we use coils, basically patients were excluded. If we were not sure that the aneurysm that we were going to treat with a flow diverter was the one that bled, we excluded it from the series. For example, in this case, you see a subarachnoid hemorrhage in relation to an AVM. Here you see the aneurysm, prenidal aneurysms, 2 aneurysms here. Those are the ones that bled, not the AVM. So in this particular case, we have 2 aneurysms. We don't know what aneurysm but bled, probably the more distal frontopolar pericallosal aneurysm, not the more proximal that is a more dissecting type. In this case that was treated with coils and flow diverter, is excluded because we are not really sure what was the cause of the hemorrhage. A second case, for example, that was also excluded is this MCA aneurysm that you can see here that was treated and coils. So if we implant coils, like in this case, so we exclude this case or these cases from analysis. This is the follow-up showing a very nice observation of the arising from the neck of the aneurysm. This is flow diverter with coils. But again, those cases were excluded. Our protocol is based on low threshold for EVD placement. This means that the vast majority of patients are going to be treated with EVD. We give pre-procedurally aspirin and clopidogrel or other antiplatelet agent. We test, and we don't place the flow diverter until we test the effect of the antiplatelets. During the procedure, the patient receives heparinization and ACT that is doubled. We place EVD in the vast majority of patients, as we said, except for Fisher 1 or 2, and except for double World Federation or Glasgow Coma Scale of 15. Yeah. So the vast majority of patients that are with impaired consciousness or important hemorrhages are treated with EVD because it's needed, or preventively if we plan the use of a flow diverter. If we are going to place a shunt, we are going to use the shunt, from using the same hole of the EVD, while transiently we discontinue one of the antiplatelets. Again, we give antiplatelets. We place the EVD in all the patients, in the vast majority of patients that require a flow diverter implant, EVD. Then we give the double antiplatelet, 2 agents. Then we test the effect after 4 to 6 hours. It means that this is, but if we are going to proceed with the procedure immediately after, we tend to give ticagrelor or prasugrel that usually act much faster, and then we test close to 1 or 2 hours after the of the antiplatelet. And only after we check that the PRU is, we proceed with the implant of the flow diverter. check that this, we are not using the PRU as is usually recommended. We use a low range of PRU. I mean, meaning 120 and below, not higher, not 100, not 180 recommended. So clopidogrel, and then we switch. I mean, we are not going to go into that. Yeah, the approach is the usual approach, nothing new. So 76 patients were treated with this approach. 61 of the patients were females, young females, 42 mean age. 50% of the aneurysms were saccular, blister 25%, dissecting 15%, and fusiform the rest, anterocirculation 90%. Most of the patients presented with a Hantages 1 to 3. Fissure is relatively important, 3 or 4, most of them. And most of them were treated in the second, third, or fourth day. So it's like, it's what usually, probably it's the most common practice everywhere. I mean, not in the first day, but the second or the third day we proceed with treatment. Classic case, massive hemorrhage. A nice case, because you see on the CT angio and the reconstruction, you don't see the aneurysm. On the 3D, the angio 3D, you see something is going on here, and 2 days afterward, this is the ventriculostomy, we detect that there is an early vasospasm sign, and the vasospasm is the one that revealed that something is going on here. And this is the same patient 3 days afterward, where you see the blister appearing here. So a simple PED, follow-up, complete occlusion. Another case, small aneurysm, probably you can put a coil, but again, it's much simpler to go with the flow diverter, as you can see here, this appearance. Or this case also, we can discuss till tomorrow the probability of putting coils here, but again, simpler and not riskier in what I've seen. So this is the case. You can see the flow diverter and the follow-up after 4 months. Very rapid occlusion. 4 months is really rapid. Subarachnoid hemorrhage focus in the posterior fossa. A subtle irregularity at the basilar tip. You see here a very, very rare blister of the P1. And this is the aneurysm. Only in the 3D is quite clear. The beginning was not so evident. Yeah. And here you see the flow diverter and disappearance of the aneurysm. Dissecting or wrap, here you see another fusiform or dissecting aneurysm of the vert. Yeah, massive hemorrhage. This patient, in fact, was a patient under. Yeah. So basically, we implanted the flow diverter a couple of months afterward. Disappear, as usually happens. EVD is placed in the vast majority of patients, 81% of the patients. Again, it's a low threshold. Sometimes neurosurgeons or my colleagues tend to complain that we place vents in patients that probably don't require clinically, but I prefer a vent placed prophylactically before we implant the flow diverter rather than to deal with the discussion of whether to implant the flow diverter, whether to implant a ventriculostomy after the flow diverter was implanted and the discontinuation of one of the antiplatelets. So PRU values, when we give a clopidogrel, the mean is 133 and lower is 44. In fact, as I told before, I prefer a 120 and below, and sometimes when I see 198, I just move to a ticagrelor. So 110 was used in the majority of cases. The PED was the one that was used more commonly. P64, BALT, and P48 was used in other cases. The nice or the funny things of this of the findings of this series is that we didn't have hemorrhagic complications. All the complications were ischemic, and most of them were transient. So out of 6 cases with ischemic complications, only 2 were permanent. 1 monocular blindness, and 1 was a right PCA occlusion. In fact, this occlusion was caused because it was a very atherosclerotic artery, and it was not related to the stent itself. It was related to the catheterization of a terrible artery. So, in fact, two patients presented a permanent ischemic complication, no hemorrhagic complications. Again, under antiplatelets, under PRU below 120 or close to 120. No rebleedings, no hemorrhagic complications, Mean hospital stay is variable. Excellent outcome in 80% of the patients. 5 patients died, and all of them because of complications of the subarachnoid hemorrhage. The immediate complete aneurysm occlusion is very low, 14%. 14%. I mean, the aneurysms are not completely occluded after you implant the flow diverter. Stent thrombosis was not seen in any case, and near total occlusion was in the follow-up in 95% of the cases at 3 to 6 months, and 100% of the cases of the 71 evaluated at 12 months. No lesions recurred. Okay? So, as we can see here, no rebleedings, no hemorrhagic complications, no EVD complications. That this is for us very important, because again, if you place the EVD before, and this is an antibiotic impregnated EVD, it's good. You can leave it for a couple of weeks, 2, 3, 4 weeks. Yeah. Ischemic complications 8% permanent, when only the immediate occlusion rate was 14%, but the complete aneurysm occlusion, we deal with small aneurysms, very small ones, is 95% at 6 months and 100 in the ones that were evaluated at 9 to 12 months. Good neurological outcome in 81% of the cases. So, what we learn from this is, first of all, we believe that there is an excellent efficacy of flow diverter as standalone therapy in selected cases of small aneurysms that are uncoilable. Yeah, no rebleedings, no patient rebled. Our PRU target of 60 to 120 was not associated with increased hemorrhagic complications as we all could expect. It's not intuitive. It's not less intriguing that an important subgroup were aneurysms that were blisters, dissecting aneurysms, or posterior fossa aneurysms that are known to have intrinsically higher relative risk of rebleeding. I mean, we deal with aneurysms that we know that they rebleed very frequently, and no rebleeding was seen after flow diverter implant. And despite the very low rate of immediate occlusion and strong periprocedural antiplatelet effects, rebleeding protection was robust. We need to remember that we deal with aneurysms in order to prevent rebleeding. And rebleeding, in my view, is absolutely protected. I mean, we don't have rebleedings. This series included only patients treated in 96 hours. Again, this is the time period where comparatively we have a much higher chance of rebleeding. The complication rate is really acceptable in comparison to other techniques. And in gross conclusion, I would say that flow diverter implant as a standalone treatment was associated with no aneurysm rebleeding despite a very low rate of immediate complete exclusion. It seems to provide a strong protective effect that is very, very important. And this effect is exclusive to this technique, because again, we are not clipping where we exclude the aneurysm. Somehow we protect the aneurysm from rebleeding with a completely different mechanism of protection. We believe that a low threshold for pre-procedure EVD placement and antiplatelet effectiveness monitoring with low PRU are key factors in reducing the rate of complications, and we showed and confirmed a very high rate of complete aneurysm occlusion. Key message: flow diverter stands for uncoilable aneurysm that ruptured, low threshold for EVD, double antiplatelet, confirm your PRU, give anticoagulation during the intervention, and if you need to do any procedure, any surgical procedure, you can transiently discontinue the PTY 12, yeah, in order to proceed with no important risks. In the future, we will see the effects of surface modification in flow diverters, and probably we will change some of the strategies. But in my view, this strategy of monitoring and confirming PRU and giving anticoagulation worked quite well in our center. Thank you so much for your attention.